that particular tumour type for which there may be a NICE approved therapy and so on. So I suppose this is a way of having now a more comprehensive way of ensuring testing across cancer types, and in solid cancers and also in hematological malignancies. And importantly, there is this directory is regularly updated so that when there are new NICE approved therapies with required testing, that they are also incorporated into the directory. And so in terms of this is a sort of bit of an overview that I will be also discussing in terms of why we want to be using circulating tumour DNA and what could be the potential advantages, as well as, you know, some of the challenges with implementation. And I think just again, by way of background, you know, a lot of this is possible because there has been, you know, so real advances in technology. And what I mean by this is next generation sequencing. So this has allowed for much more agile and faster sequencing of multiple genes, as opposed to previously when we were having to do a single gene test at a time. And I think, you know, just in terms of context, how fast this area has developed is that in 2000, when the first human genome was sequenced in the from the Human Genome Project, you know, it took 10 years and cost billions of dollars, whereas now we can do that in a few days for a fraction of the cost. And so this is, even in ctDNA, we're using next generation sequencing to be able to look at multiple genes in one go. And again, by way of background, these are the different types of next generation sequencing cancer tests that are available in the NHS. And so, you know, now we're looking at ctDNA panels, which will be, you know, panels, and they again can vary in size, but about 50 to 100 genes. But we also, for tumour testing, have large and small and medium-sized panels so that we can look at different types of mutations across different cancer genes. And obviously these panels are large so that you can have a single panel that would capture all of the different targets, all of the different genes that are needed across all the different cancer types, rather than having, you know, separate ones for each tumour type. And importantly, especially this is in lung cancer, as many of you are already aware, we have RNA panels so that we can identify fusions more readily. And so this is an example here. It's a link to the test directory. And I suppose one of the things that we need to be cognizant of is that through testing now, it's not just about detecting a single gene, but also being able to detect different types of mutations. So it may be a small variant, so when there's just one single base pair change, or it might be because the number of genes might be different, or as I've alluded to, structural variants of fusions where one part of a gene is stuck onto another part. And also importantly, I've just realized it's not come up here, is the ALK fusion that we would be testing for. So essentially, you know, we've got this small tissue sample. This is the challenge with tumour testing, is that you've got this small tissue sample, and then we need to confirm the diagnosis. So we still need to do that whether we're doing ctDNA testing or not. Then we need to be able to pick up all these different types of mutations. So these copy number changes, the small variants, the fusions. Then we might need to look at what we call pangenomic markers in some cases. So not so relevant in lung cancer, but mismatch repair, for instance, or MSI, and tumour mutation burden or homologous recombination deficiency. So different types of markers. In some cancers, we may need to confirm this with cytogenetics. And then importantly, we might need to also consider if they're inherited. So essentially, what we want to try and do is have a single test that is going to capture all of that information. So next generation sequencing allows that, but we know that there may not be a perfect test for every single tumour type, because when we have to also factor in things such as turnaround time? Is there enough tissue to undertake all the different types of tests that we want? The cost, the performance, and also importantly, how many targets do we need to cover? And obviously, I think in lung cancer, there are now more and more therapies that are targeted. And so through ctDNA, which we envisage, that in the pilot is in non-small cell lung cancer, but no doubt that as the evidence grows, we envisage that there will be a broadening of this indication to other cancer types as well. And essentially, this is possible, and many of you will know this, but just to kind of recap, the reason why this is possible is that we know that tumours shed DNA, and when they shed DNA, it is possible through a blood sample to extract the DNA and then actually undertake next generation testing. And we know that this is an effective way of testing, especially in patients with advanced cancers, because it might give a better representation of what's going on. So if you've got a cancer where there are metastases in different areas, you might get a better indication of what's going on in that tumor with a ctDNA sample rather than a single biopsy from a single location. So that's, I think, an important thing to also factor in. And so when coming on to the sort of benefits and why we're doing the pilot within the NHS and looking at this within lung cancer, I suppose a lot of it is, and importantly, I mean, a key factor is rapid results in order to reduce the turnaround time and in order to start the treatment, stratified treatment, molecularly appropriate treatment by getting those results available. It overcomes some of the technical challenges that I sort of mentioned previously in terms of enough tissue to be able to do the tests completely. And then from a patient perspective, I think, if it requires fewer visits to hospital, it may mean that they don't have to have an invasive procedure that could also be associated with complications. And then, as I mentioned as well, I think a more comprehensive picture of the mutations within the cancer, because if you've got different sites of involvement, then ctDNA may capture that more adequately. And I think, and again, from feedback from patients, it just means that it's a lot more feasible for them to be able to come up to hospital and have a blood test rather than an invasive procedure. And importantly, and that through this pilot, there will be a sort of health economic evaluation in terms of cost effectiveness of the ctDNA approach. And then one of the final things I wanted to discuss is that when we start to look at these genomic testing results, we are finding that we're getting more and more complex results. There are other cancer genes that may be identified that are not just within standard of care and within the test directory. And if this is appropriate, and we are already, we have a genomic tumor advisory board. Some of you may know it as a molecular tumor board, and it's akin to an MDT, but looking at molecular results with a medical oncologist. I chair the GTAB with Deb Sarker for the Southeast GLH, a molecular pathologist, clinical scientist, clinical geneticist, and a GTAB coordinator. So these are the details. And so if there are cases where you have any queries, you can refer to our GTAB, and this is the referral form. This is all available on the Southeast GLH website as well. So that's just sort of to really emphasize that it is to allow for the interpretation of more complex results that may come through. So thank you very much, and I will hand over to Wes now, who will be updating more about the pilot itself. Thank you.
Thank you, Nirupa. Thank you for that. Right, so the ctDNA pilot that's being run so the ctDNA pilot, it is a national pilot. It is commissioned by the NHS England, and we're just mostly talking from today's perspective about the Southeast Genomic Medicine Services region and kind of the pilot in our area. But the purpose for the pilot as a whole is, as Nirupa mentioned, is to do a health economics analysis of ctDNA testing, and therefore whether NHSC plan to use that so they can decide whether to include it in the National Genomic Test Directory, which Nirupa mentioned previously is almost like a catalogue of commissioned genomic tests in NHS, or well, England, I should say. The eligibility for the pilot so far has been radiologically suspected grade 3 or 4 lung cancer. ECOG score between 0 to 3, and for those who aren't aware, it's kind of like a functioning score, so it just gives an indication of the patient's level of function at the time. This is kind of a side eligibility criteria, but essentially if there's been a histological diagnosis of non-small cell lung cancer, but molecular testing has failed, then if the only alternative option is to rebiopsy the patient, then ctDNA sampling is eligible. And then finally, basically, the ctDNA sample has to be taken, it says here, the day before the tissue biopsy, but the way what we've been wording it is at the very latest on the same day as the tissue biopsy. And that's really for comparative purposes for the health economics analysis. In terms of the structure of the pilot, it's occurred in 2 phases. So there's been a phase 1, which started in around December of 2022, roughly, depends on the different regions, but roughly, and there was 700 samples across England. And then in mid-August of last year, phase 2 started, where there was a further 1,800 samples nationally, so 2,500 samples in total. The key differences between the 2 phases is probably important to be aware of. Phase 1, the testing was through contractual arrangements with commercial providers, so the samples were being sent off site to the providers. Testing was being done there, etc. Whereas in phase 2, it's being done in-house, essentially through Royal Marsden Hospital in conjunction. They've got a tech transfer agreement with Garden Health. So it's essentially more internal in this phase, and phase 2 is still ongoing at the moment. It's probably another thing to state. We're getting towards the end phases of it, but plan to most likely finish in around March of this year. What's the time we're going? Okay, this infographic at the bottom is really just to give you an idea of what the phase 2 would look like for a site. It's a generic version, will differ from site to site, but essentially an eligible patient is identified, discussion is had with that patient, information has been provided, etc. This might either happen when the patient is identified, or it might happen another appointment, just depends on the site. The ctDNA sample is collected and it's sent along with the test order form to Royal Marsden Hospital, the Genomic Laboratory Hub. They will complete the test, and eventually the clinician will receive a copy of the report, and at which point the local team will do some data collection, and that's really for the purpose of the health economic analysis. And then if needed, there's a genomic tumor advisory board, which Nirupa mentioned just before. Now I will move on just in the interest of time. So next steps, essentially, we need to do, so NHS, there's the health economics analysis of the data that's come through this pilot. So that's currently being done. This will then inform the NHS England's decision around whether ctDNA is incorporated into the National Genomic Test Directory. This has been delayed slightly just because of the complexity of the data set we're gathering and the time it takes to collect it. So it is slightly longer than, or slightly further along the line than we would have ideally liked. But in the interim, NHSC are looking at commissioning a phase 3. And I haven't put the details here on the slides, but essentially what they are thinking is it'd probably be around 10,000 extra samples nationally. It would likely start in around April, and would follow a very similar model to phase 2, where we've got kind of an internal genomic laboratory hub doing the testing. That's roughly kind of what it looked like. The details aren't 100% confirmed, hence why I haven't put them on slides, but just to give you guys an indication of what's next. I guess how to get involved. So if you're an NHS site, the key thing would be to email me if you can, please, and just let me know that you're interested if you've not been involved already. And I will add you to a list so that we can kind of get in contact once we've actually got further details from NHS England and once the next phase is confirmed. If you're not an NHS site but you're interested, or you've got a query or something, feel free to email me. I will find the right person to direct your question to if I cannot answer it myself. But that's the key thing. So I'll leave that up and I'll forward these slides to you guys afterwards as well, which have my email. So great. That's all for me. So case 31, this is going to be through Humna and Duraid at St. George's. So Humna, are you still happy to share your slides?
Yes, I'm just going to quickly pop
Thank
them
you.
up. Okay. So, you happy for me to proceed?
Absolutely, thank you. And just quickly, actually, questions point of view, we'll hold all the questions until all the presenters have presented, and then we'll kind of open the floor from there. So please feel free to put them in the chat in the meantime, etc., and we'll get to these. Thanks. Feel free. Take it away, Humna.
Thanks, Wes. Hello and good afternoon. I'm Hamna. I'm one of the oncology doctors working at St. George's Hospital. Me, together with my consultant, Dr. Duraid Al-Rafai, who's a consultant medical oncologist at St. George's, we would be presenting our case. It's a very interesting case, takes through pretty much things that Wes and Nirupa have just mentioned previously. And we're going to take you through the presentation, diagnosis, management, and then the role of the liquid biopsy in potentially completely changing the course of this patient's treatment. So without further ado, we will start on. So this is a case of a 70-year-old female who presented on 4th of August 2023 to the emergency department with classic symptoms of shortness of breath and left-sided pleuritic chest pain. A point of care, a CTPA at that point demonstrated bilateral PEs, pulmonary emboli, as well as an infarction in the right lower lobe. At the same time, there were some incidental findings which are suggestive of a right lower lobe mass with enlarged mediastinal lymph nodes, as well as suspected hilar, as well as supraclavicular lymphadenopathy. So for people who are non-medics over here, so it means lots of enlarged lymph nodes in the chest, as well as somewhere up over here above our collarbones. So following testing on 10th of August 2023, she had a PET CT scan, and as above, it mentioned that there was, apart from the above mentioned findings of metastatic cancer, it also mentioned that there was disease involving the liver as well as the bones. In cancer staging, we do a TNM staging, and according to that, the patient had advanced cancer, which would be stage 4. And as per the TNM staging, it was T4 and 3M1C. So this comes about to be 4B cancer. So how things go at that point, the patient was referred to the local rapid access lung shadow clinic, when that starts the 2-week pathway. So I'm just going to take back to the previous slide. These are the PET findings. So you can see over here, we can see this mass over here and lots of lymphadenopathy, and this is the involvement of the bone as well. So just a quick medical background, she had a history of left-sided hemithyroidectomy, which is a removal of the thyroid gland. That was about 20 years ago, but that was not cancerous. From the social history perspective, she was a retired pottery teacher. ECOG status, as mentioned earlier by Wes, for the eligibility criteria, that was 1. And worth noting was that she was an ex-smoker and a heavy smoker with 5 to 10 per day, like half a pack a day of cigarettes for 53 years. Just also mentioned, there was no family history of any cancer. So now, mentioning that 4th August was the start of the timeline. On 17th August 2023, when she was referred to the Rapid Access Lung Shadow Clinic, she was scheduled for a biopsy, spirometry, and baseline investigation. So every patient, once the 2-week pathway starts, these are some baseline investigations that are done at the start of the pathway. So within a week's time, she then had an FNA, which is a fine needle aspiration of the right level 4. So, one of the neck lymph nodes, we had a fine needle aspiration done, and that then confirmed a metastatic adenocarcinoma of pulmonary origin. So it was a metastatic lung cancer in very easy terms. So at that point, we send, when the biopsy is done, we send it for immunohistochemistry. It showed the PD-L1 score was less than 1%. ALK was negative, and at the same time, we send for tissue NGS. This is important to note that this was sent on 24th of August because this is going to be important when we consider the timeline later on. Part of baseline investigations, there was also an echocardiogram that was done, and The patient then was referred to the lung cancer MDT at George's. And on 11th of September 2023, it was decided that she would be a candidate for systemic treatment. She was then referred to the medical oncology clinic, and based on the current clinical as well as diagnostic information, the patient was then treated with chemoimmunotherapy approach. So this is in metastatic non-small cell lung cancer. So the patient was started on a triple regime with carboplatin, pembrolizumab, and pemetrexed. So worth noting, a timeline, 28th September was the day when the chemotherapy was started, chemoimmunotherapy as mentioned, and also was the day when reports came back from the test that was done on 24th of August, almost a month ago, that showed that the tissue NGS had already failed. So if I'm just going to repeat back to one of Wes's slides that shows that the eligibility criteria was advanced cancer and the patient ideally should be pre-biopsy. But in this case, the patient had already had a biopsy, but we can see that the tissue NGS had already failed, which made her an excellent candidate as per the pilot study. So then on 16th of October, and given the delay over here, why she was initially not recruited, I know this question can pop up very quickly in anyone's mind. So the pilot study started recruiting patients around September. So when the patient's pathway started in August, we were not actively recruiting patients at that point. So had this been started earlier, this patient would have been an excellent on-spot candidate for liquid biopsy at the point, rather than her having it when her tissue NGS failed at this point. So on 16th of October, this was when the liquid NGS was performed. We take the samples, and as Nirupa and Wes mentioned, we then send them off to the Royal Marsden. And our samples almost have a mean average of 2 weeks, and within 10 days, we do have the results back. In the interim, 26th of October, the patient had the second cycle of chemoimmunotherapy. This is important when we're going to be mentioning after a couple of slides the hospital admission that the patient came within subsequently. So almost within 10 days, on the 11th day, 27th of October 2023,